The next talk is on treating anti-TPO and TSH, myths and facts, and the speaker is Dr. Muthu Kumaran, Jayapaul.
Good afternoon, everyone. Thanks, Krishna, for the invitation. It's a pleasure to be here. My task for this afternoon is cut out as to deal with myths and facts about ATPO antibodies as well as TSH. I'm just going to give you a broad overview of how we interpret thyroid function and thyroid hormones as such. What do we do for assessment of TPO antibodies and TSH? Discuss appropriate management, monitoring in subclinical disease, pregnancy and heart disease, and the relationships between TSH, metformin, and diabetes, and some uncommon presentations where myths are so common. So you're probably well aware now that thyroid gland is governed by the pituitary gland, where we get the TSH secretion from, and we have free hormones which manage things differently with the cell receptors. Thyroid hormones are mostly protein bound, and the free hormone fraction, which is very, very tiny, is the most active part. And T3 has got a longer half-life of 5 to 7 days, whereas your free T3 has got a half-life about less than 24 hours. And normally we secrete around 100 micrograms of thyroxine every day, whereas we secrete about 6 micrograms of liothyronine. And we're all aware already that TSH is the most important test when we talk about thyroid function. And it has got a log linear relationship, which will come up in the next slide, which tells us that you've got a significant relationship between your free T4 and TSH, and very small changes in T4 will lead to bigger changes in TSH. And our current third generation assays, we can measure TSH up to 0.01. So if your lab tells you that even if it is less than 0.01, it is a lot different from just 0.02 or 0.01. So they're very, very accurate. And the debate around the normal range, whether the upper limit or the lower limit, is still under debate, which we're going to talk about in the next few slides to come again. And this new evidence suggests that various different populations have got different normal ranges. And this becomes more significant in the current argument for pregnancy. So this is what I mentioned. We've got adult reference ranges, which Dr. Kumaran has already given us a wonderful introduction. And this is what I meant. Can I have a pointer, please? When we say about a very small change in your free T4 will have a big change in your TSH. A single-fold difference in your free T4 will lead to a 100-fold difference in your TSH. This is what the log linear relationship means. And what is normal for an individual as such? Thanks. So, leave it. It's not working just fine. So, coming back, if you just have just a two-fold difference in your free, it's not coming. Check. If you just have a two-fold difference, then the TSH is a 100-fold difference. That's what happens in a log linear relationship. For a single person, you have a small difference in the upper and lower limits of normal. And this is a study which was beautifully done, measuring your TSH ranges, which is the right panel, shows that you have an almost similar pattern for each individual. And these are thyroid function tests done on 12 months every month for an individual. So you have a simple range where you go up and down, but maintain a mean, and you can have your own reference range for each and every person. And the median TSH for the whole population, this is from the enhanced data in US, it shows that the median reference range for your TSH is around 1.5. So anything more than 3 or 4, you need to be a little worried, saying that it can go up further. So what are the conditions where you would just, Dr. Kumaran has already told us many conditions where if you measure TSH like secondary hypothyroidism, you will miss conditions. But these are the other things where you will also miss if you just measure a TSH. is if you've got recent treatment for thyrotoxicosis or you're on drugs which will change your thyroid function, especially antithyroid drugs, then TSH is not something which you would rely on. You would rely on the free thyroid hormones for titrating your antithyroid drugs. Non-thyroidal illness for somebody who has been recently in hospital or currently unwell in hospital will not also give you a full picture if you just measure the TSH. If you suspect TSH as an interference, then that's also a problematic area when you consider TSH as a single point check. Central hypothyroidism, TSH secreting tumors, resistance to thyroid hormone, and any disorders to be of thyroid hormone transport can also affect your thyroid function. So these are the conditions where you would want a full profile where you want to check your free T3, T4, and TSH together. And there are other factors which would also influence your TSH per se: age, gender, body mass index, iodine levels, ethnicity, and the population you come from also matters. So if you come from Afro-Caribbean population, your TSH generally are lower than white Caucasians or Mexican Americans. And there are various populations which show that there are some populations do run a higher TSH than others. So to start off with age, as you get older, sorry, I don't have have a pointer here which works. As you get older, from your second decade, if you look at, there is 2% prevalence of elevated TSH, whereas if you enter the 7th or the 8th decade, you've got a prevalence of around 16% of chance of you increasing your TSH. And this is more common in females than males. This is also the TSH distribution, where if you look at, there are 3 populations compared: white, black non-Hispanics, which are mostly Afro-Caribbean population, Mexican Americans, and white non-Hispanics. So if you look at it, the Afro-Caribbeans, which is on the almost the 4th panel there, which will tell you they run a more TSH around the lower end, whereas the white Americans have got higher TSH compared to Afro-Caribbeans. This is almost similar data. I'll just skip this due to time. And when it comes to pregnancy, this mostly matters. And this is where the new data is evolving, that Indians tend to have a higher TSH. There are other populations like the Chinese also seem to run higher TSH compared to white Caucasian populations. So this really matters when you talk about pregnancy and treatment. Before we go into the midst of midst of the talk, I'd like to just go through what anti-TPO means. So thyroxine and anti-TPO, basically you get iodide transported into the follicular cell, which is that blue cell, and through the pendrin protein, you have iodine shifted into where it is oxidized, and then the iodinization, the thyroxine hormones are formed. The iodide oxidation happens through the ATPO and ATPO antithyroid peroxidase protein. So this is fairly important when you talk about the thyroid hormone mechanism, and you need to understand this to understand what happens with antibodies. So anti-TPO is an antibody which is found mostly in thyroiditis patients or patients with autoimmune hypothyroidism, and 90% of patients will have this antibody, and high titers of these do not correlate with the disease. And whether it is hyper or hypo, you will have the antibodies, and 90% with hypothyroidism will have it. 70% of even Graves' disease patients will go on to have this if you check them. Generally, we don't check them in Graves' disease. It's a major antigen in human Hashimoto's disease, and these antibodies tend to be generally polyclonal. What these do basically is they activate a complement-dependent cytotoxic pathway, which is harmful to our systems and our thyroid. And these antibodies are harmful through the complement mechanism, which damages the thyroid in the longer run. So that's what we mean by anti-TPO. Thyroglobulin is just a protein which is secreted in the gland, which is important. I wouldn't go into that. But anti-TG antibodies are also antibodies we commonly measure as with anti-TPO, but they are less prevalent in the community, and they are also an indicator for thyroiditis. And this is what happens if you have autoimmune thyroid disease. Genetic predisposition, and then there is environmental factors which trigger the activation of the process, whereby you get ultrasound changes, and then you get the TPO antibody abnormality, and the last one but one is TSH elevation, and the last one is your free hormone decrease. So this is where overt hypothyroidism happens. So this happens over a 5 to 10 year period, which is part of the development of autoimmune disease. And this is what happens. Your hormones steadily increases, whereas your free hormones decrease. And what do you mean by having TPO antibodies? If you have a positive TPO antibody, there is a conversion rate of 2 to 4% every year, and over a 20-year period, you will have a 50% chance of getting the disease. So this is what our research studies says. Over a long period of time, you will continuously acquire an increased risk of acquiring future hypothyroidism. And this is the introduction. And what we mean by subclinical disease and heart disease. We are all aware that hypothyroidism is a risk factor, untreated hypothyroidism is a risk factor for heart problems, and the possible mechanisms are dyslipidemia, cardiac systolic and diastolic dysfunction, hypertension, endothelial dysfunction, and hypercoagulability. When it comes to hard outcomes of treatment, we are kind of, the thought process is overt hypothyroidism has to be treated. Should we treat subclinical disease to prevent heart problems is the big question. And this is where there are a lot of studies which has been done in the past. We've been traditionally taught that subclinical disease has got no impact in treatment and shouldn't be treated. But there is emerging data these days shows that a subclinical disease, maybe in a high-risk individual, has to be treated. And the first study I'm going to show you is a Rotterdam heart study, which showed that these patients had subclinical disease, and there is a population attributable risk of around 2.3-fold. If you've got subclinical disease and you're not treated, your chances of getting an MI is 2.3-fold increased, whereas your incidence of heart disease is also increased by 1.7-fold. So this is almost equivalent to having diabetes as another condition. And following this, there were multiple meta-analyses. I'm going to just show you one particular one, which looked at cross-sectional studies based on community projects, and they looked at about 2,500 patients in each group, compared it with euthyroid individuals, and this was the result basically. So what they showed was having subclinical hypothyroidism and euthyroid state just increased your risk of acquiring IHD, so with increased incidence of ischemic heart disease in the population. What about long-term mortality as well? By just having a subclinical disease, you are inheriting increased cardiovascular risk. For those of you who do not like the graphs, this is one thing which is fairly simple, which is when you have subclinical disease, you have incidence and prevalence of ischemic heart disease, and ischemic mortality is increased. And these are, in this particular study, this risk was confined to people with age who are less than 65. So this is where the big divide happens, and the new data is emerging. And then they went on, almost the same group went on to look at the UK General Practice database, which identified a huge number of patients. Due to time, I'll just skip this. And what they showed was basically, when they compared two groups, and this is people on levothyroxine treatment and no levothyroxine treatment. When they looked at people between the age of 40 to 70, they clearly showed that the mortality rates, fatal and not fatal vascular events, was significantly reduced by when you treat with thyroxine. Subclinical disease treated with low-dose thyroxine improved this, and even the results were the same when you treat all-cause mortality as well. So there was a significant improvement in treating subclinical disease in younger individuals with high vascular risk. This was two studies again, and then this was followed by the older individual studies which almost reproduced these results. People who were older than 70 were put on thyroxine treatments, doses between 25 to 50, and they did not respond to any reduction in cardiovascular mortality. So this is the NEJM RCT for people who are already read this. So there's becoming a divide where young individuals seem to benefit from subclinical disease treatment, not so older people who are greater than 65, 70. And the same risk happens when you treat heart failure events in patients with TSH, elevated TSH as well. This we are talking about TSHs between 10 to 19, 7 to 10, and basically these are people who have got normal free hormone levels. And this meta-analysis shows everything. If you're less than 50, if you're between 50 to 70, your CVD risk is improved in younger individuals, whereas your CVD risk is not much, is not getting better with treatment when you're older, and certainly not more than 80. So this is what we are considering now. If you've got high vascular risk of ischemic heart disease, diabetes or dyslipidemia, and you've got, if you're less than 65, you might have to treat your patients even if they've got subclinical disease. What about pregnancy? Got 5 minutes. So pregnant women, the controversy here is what do we do with ATPO and the borderline TSH which we face. We are all aware that overt hypothyroidism will cause increased risk of miscarriage, preterm delivery, preeclampsia, neonatal mortality, and so on. But we are all in agreement that overt hypothyroidism has to be treated, and any TSH over 4, we will treat it. What we are going to talk about is here why these categories have been changing, and what do we do with patients with ATPO positivity. So this is one particular study. What we will look at is the US guidelines have suggested that we get your first trimester TSH to be less than 2.5 and 3 in the second and the third trimester. But more data has emerged in the last few years, and that's where the reason for the guideline change. So they've looked at more studies recently, which has shown that, this is one big slide which I won't go into, which has shown that people from different populations have got different TSHs. So people from India run a higher TSH compared to people with Western population, as well as people from Japanese or Chinese population also seem to run higher TSH. So there needs to be a consideration where you need to give a leeway for these patients rather than just assuming that they are also subclinically hypothyroid. So putting it all together, if you consider what is the percentage of women who would have ATPO positivity in pregnancy? So this is where we have roughly around 20% of all our patients, any time of the pregnancy, would have ATPO positivity. Whether they've got hypothyroidism or not is a different matter. But people with subclinical disease or mildly elevated TSH, this is what we are talking about, 3 to 4, with ATPO positivity will continue to increase their TSH between the first and the second trimester. So this slide becomes important because if you've got somebody with a borderline TSH and has got ATPO positivity, then you might have to check them all along through mid-pregnancy monthly so that you don't miss any subclinical disease during pregnancy. That's what matters. So the current ATA guidance says that if you've got TPO or anti-TG positive antibodies in your blood, serum concentrations, when patients have got subclinical, like anything between 3 to 4, they need to be monitored every month, 4 weekly through until mid-pregnancy. This is also a game changer when the study came out with whether to treat patients with levothyroxine with euthyroid pregnant women with ATPO positivity. And what they found basically was if you've got ATPO positivity and you have been given thyroxine, whether it's a small dose, 25 or 50, doesn't matter, it reduces your risk. So the left panel is something, the mid panel is what patients who have got TPO antibodies. The right panel is without negative antibodies. And if you've got levothyroxine given to these patients, that they reduce their risk completely to whatever is normal. So that's what, by just giving thyroxine, the extra risk of the antibody is reduced to almost normal, what your normal population will have. So the guidance currently is, if you've got a borderline TPO, just treat it despite borderline TSH, you need to treat it if the antibodies are positive. And this is the current ATA guideline, where more than 2.5 anti-PO positive recommended thyroxine treatment. If you've got negative antibody, more than 10 also your recommended treatment. If you've got between 4, you should consider treating these patients. Antibody negative and 2.5 to 4, you don't need to give. So if this is a significant change from our old guidance. I'll just skip this. So, and there is an again popular, that's where we stand currently. Moving on, whether type 1 diabetes is associated with thyroid dysfunction. We all know autoimmune diseases are more prevalent in patients with type 1 diabetes, and as such, hypothyroidism is also more common. And the current recommendation is basically we need to monitor thyroid dysfunction in all our type 1 patients at least yearly and at diagnosis. With type 2, a clinical history is important, and the screening is recommended only if there are clinical indicators of hypothyroidism. So this is where the myth with diabetes as such. The last but not the least is I've got, Dr. Krishna wanted me to include this because this is a popular myth that there are more and more cases of diagnosis of Hashimoto's encephalopathy happening in the city. And this is a very rare condition, which is a relapsing neuroendocrine disorder. So it is associated with high titers of ATP antibodies. And this condition is also called as steroid responsive encephalopathy associated with thyroiditis or a non-vasculitic autoimmune meningoencephalitis. So they've got different names to it, but it is considered an autoimmune encephalopathy because of its higher prevalence in females, fluctuating course of the disease, and it's commonly associated with other autoimmune disorders, and it responds to steroid therapy. So the clinical presentation presents as if in two ways. The first way is an acute stroke-like presentation with speech problems, aphasia, and generalized seizures or status. The second, it can present as progressing incidence onset, progressing to dementia and psychosis over several weeks with focal neurological deficits. Often these patients complain of lack of concentration, abnormalities, tremors, and myoclonus. But these patients respond dramatically to steroid therapy, and commonly neurologists put them on very high doses of steroids. But the current evidence for that is the role of anti-TPO in this condition is not directly linked. There is no causative role identified still, and there is no generalized shared antigen which has been identified until today between the thyroid gland and the brain. So this is probably a cause or an effect we do not know yet, but the anti-titer antibodies, anti-thyroid titers also do not correlate with the severity of the disease. So often this is a diagnosis of exclusion. So we are of the concern that it is a bit of an overdiagnosed condition currently, and thyroiditis and encephalopathy may represent two concurrent autoimmune diseases. So finally, TSH provides, my summary is TSH provides an accurate estimate of thyroid function. The current evidence suggests that young subclinical disease individuals should be treated if they have got increased cardiovascular risk. The ATPO may present as additional risk during pregnancy, and if positive, treatment may be beneficial. Diabetes and thyroid conditions are fairly common, and they remain coexistent in many populations. And Hashimoto's encephalopathy may be an overdiagnosed and overtreated condition in our population. Thank you so much for listening.
Thank you very much, Dr. Muthu Kumaran, for a very eloquent talk. The message which Dr. Muthu Kumaran has very clearly explained is TSH levels are variable between the adult and the elderly. As aging goes on, TSH is normally at a higher level. Most important is the presence of thyroid antibodies, because it only implies there is an autoimmune activity. It may translate to a dysfunction or it may not. And in certain situations, you have to, follow up to and see whether it, translates into a thyroid disease. Except for Hashimoto's encephalopathy, you do not treat anti-thyroid antibodies. You don't give steroids. And most important, it's only a marker for an autoimmune disorder. So every time a thyroid profile is done, very many times the patient again gets it done, and with the elevation in titer, they get upset. So once you have done a level, and that's a marker and it's positive, it indicates an autoimmune disorder, you leave it. No therapy for it, except in the case here. But here also we don't know, because it's possible there are other autoimmune factors, and steroids were probably not working for the TPO antibodies. It's possible there was other autoimmune disorder coexisting which causes it. Thank you so much, Dr. Muthu Kumaran. The topic is now open for discussion.
Somebody with a TSH greater than 100 and emergency surgery. Right. If it's something like an emergency appendicectomy, then the surgery has to go on. The anesthetist has to take in consideration, preferably avoiding GA as a measure. So that's if possible, the surgery can go on, provided the safety of the patient can be ensured. If it's an emergency procedure, yes, certainly it has to be done. And since it's a life-saving procedure, you have to go ahead, provided the anesthetist can find a way using a spinal surgery or a local anesthetic or so on. Generally, with such amount of hypothyroidism, general anesthetic procedures may be avoided, or they will have to choose a procedure which can be safe under that setting. With regards to non-emergency procedures, you'll have to wait, certainly. Like how to start Eltroxin in patients who are young, straight, and if it's the TSH is greater than 100, we are fairly okay. Clinical questions, if they get breathless or any chances of any heart issues, nil. Young patient, you start them on straight on 100. No problems at all. If anybody is older and you think greater than 60 years old and the chances of occult ischemic heart disease is there, then probably start slowly at 50 and then titrate it up as you go along, checking them for heart failure or rhythm abnormalities. Certainly in patients who are older than 65, 70, then you need to start them at a lower dose and work it up. You don't need to check them every time, but you need to clinically examine them for signs of heart failure and rhythm abnormalities before you perk up the thyroxine dosage. Every 10 days or 2 weeks is fine. TSH between 5.5 to 10.5, should they be treated? So this is exactly where we had the first bit of our talk, assessing cardiovascular risk. So if the patient is less than 65, then they should be certainly treated if they've got elevated cardiovascular risk, particularly in our population where diabetes is more common. If they are more than 65, you need to think twice, get their TSH checked a couple of times at least before you initiate treatment. The data is certainly there for younger individuals with higher cardiovascular risk. Certainly above the age of 70, we do not treat patients less than 10. So that is something which you need to take care. So older patients, you need to hold off from treatment. And obviously the risk of osteoporosis and atrial fibrillation is also high if you overtreat the patient. Do we need to add TPO in all our routine thyroid profiles? Certainly not. The first screening test is your thyroid function test. If you do find any abnormality, yes, please do. If you have got subclinical hypothyroidism, then to assess risk and your screening frequency, ATPO will be helping you. But if you do have patients with subfertility and then minor variabilities of thyroid function, they may help. But this is only an exceptional area where this will offer help. There is nowhere else it will offer any extra. Other than pregnancy or subfertility, this might not do any good. Thank you, sir.
Thank you, Dr. Muthu Kumaran. The third talk is about Dr. Jayashree Gopal, and she will be talking on the patient with unusual fatigue and endocrine approach.